I wanted to underline right at the very beginning that this entire discussion, and in fact the entire series, is a series of discussions which are primarily and very avowedly partisan. Partisan in the sense that these are on the side of people who are most disadvantaged. So everything that we are discussing, more or less is following perhaps the talisman that Mahatma Gandhi had left for us a few months before he was assassinated. When you are in confusion and doubt, remember the most vulnerable person, the weakest, the most disadvantaged person that you know, and think whether what we are doing is making sense to her. And I think that is primarily what we are trying to do in this discussion and in everyone that follows. Is it making sense to that most vulnerable person? And I wanted to also say that disadvantages of many kinds, in the context of the urban poor even more sharply, but I think also with the rural poor, we could look at disadvantage in at least three kinds of axes. The first is, the economic disadvantage of livelihood and income. So people whose employment is, who are, have uncertain employment, are paid very low wages, work in unsafe conditions, have no security, etc. So I think that's one kind of disadvantage. Very importantly, there's a second axis of disadvantage, and that is of the kind of habitation that you live in. So homeless people living in shanties, living in under plastic sheets, etc. It's important to remember them because when the whole prescription is around social distancing and washing your hands regularly, I mean, it's just so extraordinary that we keep talking about it to a people who live, perhaps in a 10 people in a 6x8 or 10x10 shanty, and you're asking them to spend 40 days cooped up in that space and to wash your hands when 150 people share a common toilet. So you can be occupationally and economically disadvantaged. You can be disadvantaged in relation to your living conditions. And there's a third axis of disadvantage that I request this entire conversation and series to bear in mind, which is social disadvantage. So disadvantage, as a single woman-headed household, children without care, people of Dalit and Adivasi communities, Muslim communities, which are particularly targeted today. Social disadvantages of age, of gender, of sexuality, and so on. And very often, very sadly, all of these three kinds of disadvantages overlap one upon the other. So the occupationally disadvantaged can also be socially disadvantaged, can also be, and is quite likely to be disadvantaged in terms of habitation and habitat. And when all of these pile together, they lead to even greater vulnerability, disadvantage, or let us use the much clearer term, dispossession and oppression. And I think that it is from the perspective of all of these people of disadvantage that our conversation today will make the greatest sense. When we were planning this session, Vikram Patel in particular said, let us be forward-looking. And by all means, let us think for the future. Whatever has happened, where do we go from here? And that will be really the focus of our discussion. But I think that briefly, just one round of discussion, one round of observations from all of you on whether a stringent lockdown in principle as an idea and in the way it was executed. The execution was hugely faulty, but was the idea itself correct? was it the only or the best public health option in order to fight the pandemic? In a country where vast populations have no assured income, no food without work, do not live in conditions where social distancing and intense sanitation are possible. And if not, what could we have done uh, differently? Uh, as I said, this will be just one round of looking at where we have reached so far, and from hence, and the rest of the discussion will be forward-looking.
Harsh, I think it's first of all important to understand what is the purpose, what is the objective of a lockdown. It's quite simply to enforce physical distancing to slow the spread of the epidemic. It's very important that this is absolutely understood. The lockdown achieves nothing else. It does not achieve the elimination of the virus, and it does not achieve the eradication of the epidemic. It doesn't do any of those. And I think this is a basic fundamental fact that we have to actually start with. And so then the next question is, are there other ways in which we could have slowed the epidemic and done physical distancing that are equitable and practical in our context? That really, to me, is the fundamental question. And I think there are many ways. Obviously, the horse is bolted. The train has left the station in some respects. I mean, it's now easy to look back in hindsight as what we could have done. And that's why I feel that we should be forward-looking. But since you've asked this question, if I was in charge, I would have done things in a very different way. First and foremost, I would have planned the lockdown. I would have given the country enough time to plan for what is going to happen. I would have allowed public transportation to continue so that people could actually get home. My 86-year-old father is trapped alone in his apartment in Bombay. There is no way I can get him to come to live with me or for me to go live with him. I think this is simply cruel. And of course, this is my class of society. I can't even begin to imagine how harrowing it is for people who are living on the breadline. The second thing I would have done is that I would have done it in a staggered way. I would have definitely used some form of physical distancing or lockdown policies in those areas where there were clusters of high transmission. That is a very good epidemic management policy, but I would not have imposed a total lockdown on 1.3 billion people. I don't think there was any reason to do it when it was done then. I think there was certainly reason to do planned and staggered physical distancing. The third thing I would have done is I would have implemented right at the outset a very clearly defined proper strategy for case identification. And Harsh, here again, I think another issue that we should really consider is the heavy focus on top-heavy medicine and technology here. You know, it's all about PCR diagnostics and intensive care, but actually India's greatest public health success, and I speak amongst people like Sujatha and Keshav, and they can speak for themselves here, but our greatest public health success has not come from the tertiary hospital. It has always come from the community, the primary healthcare system. I got disconnected. I was just finishing. I was just saying that I wish our communication had been a little bit more balanced, that it would have really invoked our solidarity with one another rather than to invoke our fear of one another. And I think it's the fear element which I feel was misplaced. We should have really invoked the support element. Keshav, over to you.
Yeah.
Okay. Harsh, may I come in?
Yes, please. Super.
Yeah, I was only going to make the point. I mean, everything Vikram says is absolutely correct. Lockdown was clearly not thought through. We will talk more about this whole business of people thrown out of work and trying to get home. Clearly, those were aspects that no one thought about. But I think we should also remember that at the time when lockdown was announced, which was 24th, 25th March, when frankly, I don't think anybody in government had any information. And it seemed to, at that point of time, it probably seemed to them that that was the best they could do to control the spread of the epidemic. Not knowing, not having enough information, and really not knowing what else to do. I think we have to admit that one way or the other, lockdown has, in many parts of India, controlled the spread of the infection. Unfortunately, we squandered the time we saved. We did not use the time we gained in either strengthening government hospitals or in increasing the pace of testing or in more carefully identifying which areas were more susceptible what Vikram was talking about, the clusters. Chennai, where I live, there are contradictory messages coming out all the time. Many relaxations have been introduced, but we have a very large number of what they call areas of containment, red zones even now. And no one really seems to know what the correct thing to do is. So the limited point I wanted to make was, and I think Vikram did not really get to, what else could they have done around 24th, 25th of March when they didn't know too much other than the fact that the infection had entered the country? I think it may be useful to spend some time looking at that. Thank you.
Yeah. Thanks so much, Sujatha. May you come in now, please?
Thanks, Harsh, for inviting me. There's not much that we can differ with what Vikram and Keshav have said. It was totally ill-planned. I think that's an accepted fact of the matter. But even if it was ill-planned, lockdown, once they announced it, they should have gone the full hog and done the entire strategy properly, which meant really that that was a time given to them to expand access to testing, to isolating those who are infected, quarantining them, and doing a massive information campaign of do's and don'ts and generating community understanding of what we are in for. None of these things were done. And we wasted so much time in trying to just go on and on putting up ventilators and ICUs and so on, which is the last bit of the whole epidemic. And even today, if you see Bombay, which is in such a mess, most of the time is going in putting out these open air quarantines in that Mahalakshmi and so on, not understanding that on 7th June you have the rains coming in, and then what happens to all these temporary facilities. So I think there is and what has really appalled me is the way the Ministry of Health has been sidelined, the way the technocrats of ICMR took over, the way they constituted committees with no epidemiologists involved. I mean, there were one or two from NIE and so on, but then the chair is the DG ICMR. So you cannot really expect Ganga Ketkar and all to come up with anything different. And we have enough experience in this country and a large number of epidemiologists who have been directly involved with both the HIV and the polio programs. And HIV in particular, I mean, as I keep watching this whole epidemic evolve, every moment I could see what's going to happen next, only because of my engagement with HIV. It just has so many lessons to teach. All that memory, all that knowledge is available, and it was not used. And that's a very big tragedy, I feel. Now, I really don't know what has happened in Delhi that they just simply sidelined all this and went on to, AIMS clinicians taking over the entire program and set aside public health specialists. So that's something that I've been very disturbed about, because we've made one mistake after another, unplanned. Now even the exit, of course, we'll come to that later on, I suppose. But the way we are trying to also continue with the lockdown seems so lacking in strategy. My last point I'd like to make at this stage is I'm amazed that there is no uniform guidelines for, say, testing strategies. So every state does its own bit. Kerala did one set of actions, which they proved to be very efficacious. Telangana has no strategy at all. So it's the chief minister who decides. There's no information available to anyone. So he decides that today symptomatics may be tested, next day asymptomatics may be tested. So one doesn't know what's going on. There's no testing strategy in Bombay, as you're seeing from the media. Every day, commissioner comes up with his own understanding of what kind of testing strategies to follow. So the whole issue of testing itself is a mess, even today after so many days. That I find very, very strange. Not to talk of the fact that we still don't have adequate kits. And I remember in March, mid-March itself, when I used to be called to the TV and so on, we were all shouting, testing has to increase. If you remember, there was a time when we were doing 5 tests per million. And it was so evidently ridiculous. And it took so long, almost over 10 days or 10, 15 days for ICMR to get out of its denial and expand the testing strategy. They kept on saying that their strategy was the best and that we should stick to travel history and those related to those having had travel history. The second is they still continue to deny community transmission, where there's so much evidence available that there is a community transmission on, and we still don't have our strategies on how to deal with a community transmission-led epidemic. So I think, you know, this continued confusion at the top is something that's very disturbing and extremely worrying as far as I can see the way the epidemic is going. We're making far too many mistakes, and it's going to have a lot of implications for us. Not to talk of the social cost, the economic cost of the lockdown and so on, that we will come to later. We know it, it's evident. But just the technical aspect of being able to contain the epidemic. And lastly, I'd like to point out that, as Vikram said, lockdown has a specific purpose of slowing the epidemic, containing it within a manageable boundary and all and so on. But it really hasn't bent the curve, as they keep on saying. It has slowed down for sure, but the RO is still very high. We haven't really achieved much of a success anywhere except Kerala. And so I think there is, you know, lockdown, in my opinion, when we review it later, seems to have been a failure. We have paid too much of a social cost for not that much of a gain. But having said that, I still do believe that maybe the lockdown, if planned well, after a week from April 1st, with everything planned properly, would have had its dividends for sure, and a much better outcome than what we have today.
Thank you so much, Sujatha. I think that was also very comprehensive. For the remaining panelists on this first point, what could we have done differently? Suppose you were the Minister Health, and what would you have done differently is something that we could also focus on. So Vandana next, maybe.
Yeah, hi, thanks Harsh for inviting me. And I mean, just a small disclaimer, I'm no longer joint convener of Jan Swasthya Abhiyan, but I work very closely with Jan Swasthya Abhiyan, also the Right to Food campaign. I also want to mention the medical support group that's been really working, crazily, really so hard to be able to facilitate healthcare to people living in slums in various cities and even in rural areas. So I just want to mention that. You know, I think we're a panel of fairly like-minded persons, and we're going to mostly agree with each other and hold to each other's views. I think Vikram has already highlighted what he might have done differently quite well. I mean, it's a case of bringing granularity. It's a case of timing. Timing is critical. But one point that I do want to make, Harsh, is that, you know, it's not just from the equity, ethics, humanitarian, livelihoods point of view. What we have actually done is bad public health. And I think that it's critical to be able to frame it in that way, at least by public health experts. It's bad public health to not think of social determinants, to not think of equity, to not think of medical conditions that are not necessarily directly related to an infection by the COVID virus, but very certainly related, causing morbidities and mortalities because of the response that we have created. So I think that we must very surely keep this within the public health domain and not be tempted into thinking of these things as collateral damage and so on. I mean, just in terms of data alone, many people are now making the same points in mainstream editorials. Vikram has, brought out a paper. We ourselves are trying to publish one. We are placing data on COVID-19 deaths practically by the hour. Where is the data on heart attacks, that have not received? And we are seeing this. I'm seeing this on a daily basis thanks to this support group that I'm associated with, the maternal mortalities and so on and so forth, which only the media is picking up on, and activist groups. And the government should be, totally held accountable to letting us know about all that as well and taking that into account. In fact, I mean, that should not have happened in the first place. But now that these things are happening, you must moderate your response, keeping all this evidence and this data in mind, the distress deaths are part of that. Hunger is part of public health. I mean, lack of food is part of public health. So, I mean, that's one central point that I wanted to make. I feel that, you know, this grand gesture, you know, with very little thinking through is very, very symptomatic of this current government. We've seen it before with less dramatic, you know, outcomes and impact, but it's just really the same thing, lack of planning. I think that one point that was made is very important to understand, that we've transposed a public health problem into a policing problem, into a law and order problem. And I think that that is very, very important to understand and to fight, to resist. Because really there's no way that this pandemic can be sorted out in that particular manner. I also want to say that it's not that there is no decentralization. It's a wrong kind of decentralization. It's a classic case of decentralization without building capacities and providing support. So somebody did mention that there's no devolution of finances to the state governments. That's very, very important. Secondly, as Vikram also pointed out, that the state leaders and even the RWs, I mean, what they have done is actually increase the stringency of the lockdown. I mean, in Uttar Pradesh, they've increased the stringency of the lockdown. RWs have gone a step further to do even what central government is not recommending, simply because they do not understand the objectives of the lockdown, and nobody is bothered to, you know, make sure that they understand that. So when we say we must decentralize like Kerala, but, you know, Kerala has a long history of decentralized governance that works well because of the capacities it has. So I think we need proper decentralization. Let us learn some lessons from this whole thing. This thing is not going to go away soon. We're going to be seeing a whole lot of, I think, mortality creeping up. I'm going to stop, maybe come back later at some point. But I also want to just place one, you know, paradox or something that I'm struggling to understand, which is why the UK has suffered the way it has. I think it's worth analyzing. They have a very strong public health system. They also have very strong social systems. I've been, you know, a part of that in some sense. And they have, you know, a community that is not as variegated as our own, and yet look at the mortalities there. Is it something to do with demographics or whatever? But it's you know, something to think about. I also feel that we must not underestimate the you know, the nature of this pandemic, and we cannot also play it down. It is a very, in the best of circumstances, we are in a very, very difficult situation in the world and in this country in particular. I'll just stop there for now.
Thanks so much, Vandana. I think Sundar, could you come in with your observations about how you assess what has happened so far?
I think most of it is said, and Vandana has just made the point about policing versus public health, and I think that's a very, very central issue, and I've not got too much to add. Let me just make one, just an observation. Suppose we had allowed all the migrants who wanted to go back home the week before the lockdown. On March 14th, we had 100 cases, even if we say 1,000 cases. The spread would have been of 100 cases. Now, when you lock them in, you have actually incubated the whole infection within those quarantine centers, which one has no sense of quarantine in them. And now you are letting out 60,000 people we are actually going to have. Just think of it. If we had actually let them go, the disease, the stage of the spread it was. So somewhere the ethical principle that people have a right to return to their family. The more you frighten them that you may die, there is an epidemic, the more you want to get back to your family. Between the basic understanding of ethics and between a basic value and rights and public health, that actually makes a lot of connection. We sort of missed that. The other surprising paradoxes, I just want to draw your attention to two paradoxes. One is, we have a system. We built it up after the swine flu, but we had started it before, the Integrated Disease Surveillance Program. You know what happened to it? Its last report goes up on the February 1st week. It has been reporting weekly from 2010. In the last report, it faithfully and brilliantly reports the first 3 COVID cases of India and then goes silent. No further reports are put up. No further information, and I believe it's not just not put up, it's not even on flow. So you have built a system at some effort, particularly for managing epidemics. And when the epidemic comes, the first thing you do is let go of it. And similar thing we do with the public hospitals. You have top-line public hospitals, which actually provide a huge amount of care, which are willing to run despite, because they have the notion of public services where many other hospitals shut down. But what do? You actually empty them out and keep the beds empty in anticipation of an epidemic that should arrive. So when we say we created 1 lakh additional beds, we've only repurposed existing beds and reduced the total amount of care available within the public sector in effective terms. Because unlike the other places where new hospitals came overnight, over here what you actually did was repurpose essential. So you use it for residual care. Before you had a minimal package. Now you say, okay, COVID-19, nobody will handle, I'll handle this, but what I'm handling now, let somebody else take care of. So the point I'm making is this: the health system preparedness for which the country sacrificed so much, the migrants are satisfied, families have been the center. It actually not only did not happen, it took a bizarre turn, at least on these 2 areas. One is the disease surveillance program. It's been disrupted by the epidemic instead of actually being built up by it. And the second is on the whole area of the public care that was there. So this whole repurposing of central public hospitals without any substitute arrangement has been actually not the way that health systems preparedness was conceived. These are serious issues, and I'll stop with this. The rest, actually, I endorse. They have already said some of those issues.
Thanks so much, Sundar. And finally, Vikas, do you have anything to add? I think the next question I'll go the reverse, so that, because I think a lot has been said, so we will go in reverse direction so that you all have more to say on the second question and so on. But Vikas, is there anything that you want to add to what has already been said?
Yes, I wish to add just a little bit. Many thanks for having me on this discussion. See, beyond just being appallingly planned, I think the way and manner of imposition of lockdown was very, very criminal. You see, none of the consequences which followed, they were not unforeseeable. We had all the information about the conditions of living of our people, about the size of informal sector workforce and all. And unmindful of all those things, the lockdown was implemented. So I think it had a very pronounced class bias in the manner it was carried through. Secondly, one lasting impact of that lockdown has been that it has confounded our strategies to combat this pandemic by portraying it's probably the worst victims of this pandemic as the criminals or as the most dangerous ones. Remember how police treated these migrant workers, the lathi charges and all those kind of things. Then we had minorities getting targeted and all that. So, and this is all carried on the way in decisions as recently as that one state government deciding, we will not let these migrant workers go. So all of this, it ultimately fits into this jigsaw puzzle. Lockdown has not just been carried out badly, but it has confounded our strategies. It has confounded what needs to be done and all. And I think the result is that those who ought to have been treated as victims of the pandemic are now being criminalized lest they fall sick or something. We have reduced human beings to be treated as vectors of the disease, and it was very, very evidently visible. I think this is something, it's not just that, okay, it was done, it was a mistake and all. It wasn't really that way. And this thinking continues to cast a shadow on what the government is doing as of today. This is what my submission is.
Thank you so much, Vikas. I think that we've reduced people to vectors of disease and also to a labor force and not human beings with the fullness of human agency and aspirations. I come to the, we promised that most of this discussion will be forward-looking, and we have to look forward. Before we come to the third question about what you feel we need to do, is the question, what does the future, immediate future hold? That the whole, we had promised that we would make this discussion much more future-looking, the rest of this discussion future-looking. But my first question before what needs to be done is, what does the future hold? As public health professionals and administrators, it's so, for all of us, one set of people had told us that by now there would be bodies in thousands and lakhs and so on and so forth. The number of people dead would have been huge. Clearly, a lot of the understanding of how all of this is going to play out has not, there are too many different understandings of even what is going to happen. There's an inbuilt uncertainty because it is it's a new virus and we don't know how exactly it's going to play out. But my question is a difficult one for all of you. What do you really feel is going to happen in the coming weeks in relation to the advance of COVID-19 and the epidemic? And in particular, what is going to be the kind of impact on all of these kinds of vulnerable groups? And I talked about three kinds of vulnerability: people who are occupationally, economically vulnerable, people who are vulnerable in terms of their housing and habitat, and people who are socially vulnerable. So my second set of questions, and I'll go quickly in reverse direction. If any of you would like to hazard now what is going to happen in the coming weeks in relation to the advance of the virus itself and the epidemic. So Vikas, I'll start.
See, I mean, I wouldn't make any apocalyptic kind of statements, but one thing is there that as far as virus itself is concerned, this virus doesn't seem to be particularly vicious in terms of its pathogenicity and all that. But I say still, given all that we have done till now, and all the other things which have happened. See, diseases never just are played out in terms of host and the pathogen. It is the epidemiological environment which casts the manner in which diseases will play out. I don't know to what extent hunger has been enhanced as a public health problem, except to say that yes, it has been gravely enhanced, but what it has actually done to the people's bodies, their abilities to be able to resist infections and all, and not just infection because of the virus, because of other numerous infections which are usually prevalent and which are major contributors to morbidity and mortality in India. So what we are going to have is, in my considered opinion, not just the problem of the virus per se, okay, in as much as it is going to be the problem of overall health crisis, wherein virus casts its effect along with the impact of all other pathogens which are endemic to our country as such. That is one of my biggest concerns right now. See, and given what is going to have to, what has already happened and is further going to happen to the livelihoods, the chances are, I mean, even more fearful. And the government on its part is trying to make this into, as one of the senior journalists commented the other day, turn it into a good epidemic, a good pandemic, a good crisis. That is abolishing labor laws and everything. So again, the burden of that is going to be borne by those who have already been harshest hit during this pandemic. I'd conclude at that, right?
Thank you, Vikas. that's a somber start to this round. Sundar, where would you, what do you see the immediate future hold?
Harsh, you are inviting me to speculate, and I am very hesitant. I wish I could do a small time travel 6 months and then have that knowledge and then tell you exactly. And these mathematical models, I was a bit skeptical of them. Everything I've seen made me much more worried about them. They don't seem to understand other diseases. They move like marbles in a free vacuum. They don't actually relate to many of the things I know. So I can draw on two things. One, this epidemic is remarkably, though it need not be, like the 1918 Spanish flu pandemic. Remarkably like that. The whole Bombay concentration, the spread, the north and the west and the south gets it, and then it spreads in. And I wish the last part of it is a bit true, because as it moves, it lost a certain bit of its mortality rate as it went through. But the bad point about it is it will hit the poorer much more. So it is going to affect the rural areas late, but it will go in there slowly because there are distancings, it travels. Where the mixing is much more, it moves much faster. But then where the rates of mixing are lower, it moves in, but it slaughters much more. So in some sense, I think we should look at it as whatever is the model saying, we need to be prepared. We may be optimistic because there are ameliorating factors, but we have no business in public health to do anything but to expect that it will go the way the virus has behaved elsewhere, meaning it will go to rural areas, it will go to more vulnerable communities, it will cause greater mortality among the malnourished, and therefore the entire system, we can only say that it will peak somewhere between September and November, and that means 3 more months for us to prepare. But you know, it's already increasing quite a bit, and therefore we need to be not at all sanguine about the fact that Assam is low, Orissa is low, Chhattisgarh is low. It's still reaching there. We are still at an early stage. We are not even reached the midpoint is my guess about it. But thank God then we have still got time, because we've squandered a lot of time. We can do better if we start working on it right now. You know, at least in April, I saw the first signs of them trying to do indigenous manufacture of some of these commodities. At least some discussion was beginning to happen on those issues. But I don't know whether it's on scale and whether they are doing it where they need to do it.
So Vandana, again, how do you look at the future?
I agree with everything Sundar has said. There's just one thing that, you know, is standing out for me when I'm looking at the world and how things have really proceeded. And that's health worker mortality. I mean, there's just no getting away from this very, very tragic thing that the frontline workers, the health workers, whole families of doctors are also getting wiped out here and there. So, you know, there is something here which is slightly different from a flu epidemic and so on and so forth. So that's a big concern, and that needs to drive a lot of also our interventions. And as a society, as well as in the health system itself. So that's just one point that I wanted to make. And I think that apart from everything that Vikas has mentioned in terms of, you know, one can think of the impact on non-communicable diseases that are not resulting in immediate mortality, but definitely morbidity is going to increase because the health system is so, as Sundar had pointed out, so diverted. That's one. The other is the lack of you know, PHC, primary health care, which is ridiculous considering the WHO, even the most recent guidelines have clearly said that PHC must continue. So things like immunization, I mean, just think of it. If on top of this, you have now you know, a mini epidemic somewhere of diphtheria or something, these are things that do happen. You know, it's ridiculous that we have really invited that upon ourselves. So it's not a happy scenario, but everything shall come to a pass. And there are many people who have suggested that India might have lower mortalities. We hope so. BCG might be playing a role. We hope so. The vaccine might be developed fairly quickly. We hope so. That this combination of at least 3-4 drugs that we have in hand, you know, azithro and so on, and then also plasma, treatment, might be used in emergencies even while we are validating these. So we hope so. In the longer term, we hope that somebody will take very serious lesson for the whole country, for the public health system, for the privatized version of public health system that we have so far, for decentralized governance, for financing of the health system, and so on. And I think that as a group, we need to keep pushing for the short term as well as correct for the long term, because I think that is correctly pointed out by Vikas again, that the retrogression that is the potential in this whole thing is immense also. The more autocracy, more centralization, more policing, more kind of human rights violations in the same lines as some other countries suffer. So I think that that risk is very much there, and so we have to be alert to the short term as well as long term, and have our finger on both pulses simultaneously. It's very tricky, I think, for all of us, and of course it is tricky for the government, and so support to the government also has to continue side by side. But I think that cases are going to go up, numbers are going to increase. This is something we have to learn to live with, and definitely the leaders need to understand that. I mean, there's no point jumping up and down every time one new case comes up and making a big drama of it, because that's just expected, and that's just how the epidemiology of this is. And I think that is one fact that really needed to be hammered home right in the beginning of lockdown 1, and that didn't happen.
Yeah, thank you, Vandana. And the impact, the fact that the worst is very much in the future. The disproportionate impact on health workers and on the poor. Sundar talked about the rural poor, but I think that the urban poor are going to bear a very, very heavy burden because of the conditions of their life, which facilitate very fast spread of the contagion. Sujatha, from all your experience of a very different kind of epidemic, which was the HIV, which you handled so well, how do you look at, not at strategies, but what do you think the future holds in your understanding?
So, Harsh, I mean, till maybe 10 days ago, I was really so sure in my heart, not in my mind, but in my heart, that somehow the virus will now run away with increasing temperatures. And, like it happened in H1N1, there was a dip in June. If you really see the trajectory of this epidemic, very well following the H1N1 pattern. Same old Gujarat, same old Maharashtra, same old Karnataka, Delhi, same way, and same increase, peaks and all that. So I thought, since it's so obediently following H1N1, it would also dip in June, and then when the rains come, July and the winter, we'll have another second wave. But by then we'd have got our tests. These famous test kits would have flown in by end of May, and maybe would have got our act together better to deal with the second wave. But unfortunately, the wretched virus is immune to temperatures. So it's rising steadily. And I really think that it's going to be a huge surge in the future. And why do I say that? Till now, Bihar and the northern states have been relatively protected. Now, data that's coming in is that the migrants who are going, the point that Sundar and others pointed out so well, is that the migrants have taken back the infection. And what's happened in Bihar, they're not even doing testing and quarantining. The minute they get off the train, they've been put in the buses and sent off home. And the panchayats said, we have no more money to feed anyone, so just go home. So this is what is exactly happening today. And as you saw, in a day's time, we came across reports of more than 68 infected. Almost every district today has one or more of these infections. And I know the Bihar system is so immensely fragile that I really don't know how they're going to be able to cope if there is a surge of these infections. And what I worry most is that, as a journalist was telling me yesterday, the class bias is so apparent that, that the labor, the poor are going to suffer these infections from now, and they're not going to get that kind of treatment that they really should. So, for example, in Telangana, they've said no need to test the people who have been treated unless they have continued to have, even if they have any symptoms left, they should after 10 days be allowed to go without testing. So we don't know what's really going on. So on the health front, I'm very fearful of a higher increase of morbidity and mortality, particularly among the poor, the health systems of the North in particular not being able to manage this kind of surge. And I don't know what's going to hold in store. That's one. The second is economic. I really do believe that impoverishment and this kind of economic lockdown is going to have very serious consequences for us. As Vikas rightly pointed out, the hunger issue is a very serious and a major issue, and the immunity levels would have fallen worse. As it is, we are such a malnourished people, and therefore the other morbidities are really going to play up also. The trauma that the migrants and the labor have gone through is going to have a lot of economic implications for our society as well. So, and what's going to be happening is that the response will be that most of the economic engines will try to use technology more and more to sort out issues, and job opportunities in the long run may also reduce. So, you know, these are the kind of measures that medium and long term may have for us due to this pandemic. But right now, I'm very fearful about the future. I'm not one bit comfortable. I still don't think the government of India has it all into one shape. Now they're beginning to already forget the virus. They're beginning to talk about economic repercussions or financing packages for MSME. That's all important. I'm not saying no, but not without, that should be done within the context of the epidemic and continue the focus to see that morbidity and mortality on account of this virus is contained at all costs. I'm just very afraid of the shifting attention and leaving the poor to their own fate. This kind of shift in priorities is something that I'm fearful. Do you know that in the last 4 months, federal government has only given 18,000 to 20,000 crores to the states? There is no liquidity in the state. There is no money. And that's the reason why they had to open those silly liquor shops, because liquor is the only way of getting more additional resources. What a tragedy. Even petrol is another source, but as you know, no vehicles and so on, so petrol revenues were not so buoyant. So, you know, this is the kind of, unless and until the government of India opens its fist and allows in more money and gets a more balanced perspective of this whole issue, I'm afraid we are really going to be in deep trouble. I just want to end saying that as most people believe, health is a state subject. It is for many areas. But insofar as infectious diseases and epidemics is concerned, it's very much a center state issue. It is a shared responsibility. Mind it, it's in the concurrent list. It's not in the state list. Secondly, this has now been declared as a disaster under NDMA. So in balance, the union government's responsibility for what's happening, the financing of it is much, much more than that of the state. So unless and until we get these kind of principles understood and the central government is genuinely concerned about trying to get an economic growth moving again by containing the epidemic, I think we are in for a shock. If you want numbers, I still think that we may touch 2 to 3 lakh cases, and we may have anywhere between 5 to 10,000 deaths, but that's only my own hunch. Take it or leave it. I'm just faking these figures, but you know, that's what I feel may possibly be the reality. Thanks.
Thank you, Sujatha. Keshav, this is...
Yeah, thanks, Ashin. We've listened to some very, very thoughtful and important stuff from Sundar and Sujatha. Harsh, you asked the question, what are we looking at? You know, where are we going in the future? I'd like to call attention to, I think there are 3 categories of persons who need a lot of attention in the months coming ahead. I mean, the first is babies. And Vandana mentioned this about how the universal immunization program has in some parts completely collapsed at this point in time. At the best of times, the last figure I could see for all India was 62% coverage. It may have gone up slightly, but that was before COVID. Now, if that program has been affected, as they say it has been affected in many, many states, then we are going to see, and Vandana mentioned this, the possibility of infections, diphtheria, measles, all this sort of stuff happening. So how do we address this population of babies? What, 26 million born in India every year. So this clearly has to be a priority. ANMs, Anganwadi workers, these are the only people we have on the ground to work in this area. So that is an area that needs a huge amount of government attention. That is one category of people. The second category of people, I mean, Sundar talked about this, how COVID beds are being created because other patients are being thrown out. Now we keep seeing reports in the papers about people with TB who are missing out on their treatment. People with other conditions, non-communicable diseases, people who are not getting their diabetes medication, their hypertension medication, who are completely falling off their own map of treatment or care or whatever. So we need to find out who are these people, what have they lost in terms of treatment and care, how can that be made up? Do we find them? This is again a very, very big, a very large number of people who need help. And the third category of people are unorganized labor who have been thrown out of work and have lost all income and lost everything. Now, they may not actually have been the migrants who have walked home, even if they continue in Mumbai or Chennai or wherever, they are without jobs, they are without their daily income, they are somehow managing to stay alive. We don't know what the impact is on them, either the ones who continue to stay where they work or the ones who walked home with no income, no food, nothing to look forward to, the possibility of death, people they know have died. I mean, Vikram will tell us about, what are the implications of this for their mental health and well-being. There are already reports about increased attempts at suicide, increased rates of attempts at suicide. There are already reports about increased domestic violence, unwanted pregnancies. All this has happened. So I would really urge that these three categories, babies, existing patients, and unorganized labor who've been thrown out of work, need specific attention, which only government can give. None of these people are going to get any solace out of either the private hospitals or Ayushman Bharat. This is solid public health work that government departments need to do. And one last point, Sundar made the very important observation that India's great successes have not been hospital driven, but have been community driven. That is actually very, very important. But in the future that we are going into, I would make a case that government really needs to invest in district hospitals. Somebody needs to take the lead, and that is all that we have to cope both with people who have tested positive for COVID and need to be treated, and for people who are not COVID affected, but who have been affected very badly one way or the other because of COVID and everything else. And while hospitals may not have played this sort of role in the past, they may need to do so in the future. Thank you.
Thank you, Keshav, for reminding us about who will be most vulnerable. I just wanted to sort of underline one thing that, we focused a lot because of the heartbreaking scenes of migrants leaving. But there's a large segment of the urban poor who have nowhere to go. They are not going away because they have nowhere to go. And a lot of the homeless people that we see, or people who have now, denotified tribes who have settled, who are in the city, there are various other people. I have been going with our food solidarity feeding work with my colleagues over several days. I just wrote a piece where I basically said I have seen scenes of mass hunger in rural India, both as a district officer and as the Supreme Court Commissioner, looking at the right to food. I've seen starvation. I have never seen mass hunger, not in the future, but now, of the kind that we are seeing in the city already. Where you have really people, to have people spending the entire day standing in line for a small sort of ladle of food. And there were people weeping. I stood for 3 hours. At the end, the food ran out and they gave me 2 bananas. And what do I feed my children? And these are now not stray cases. There's mass hunger already visible, not in the future, but now in our cities. I think the mass hunger of the countryside is going to follow. So Vikram, your prospects for the immediate future, please.
Well, I have to say I can't. I mean, you know, everyone. I agree with everything everyone has said, but it's so demoralizing to hear, you know, Harsh, your remarks right now. It just makes you feel so completely defeated. That in a country with so much wealth in its people, such an incredibly strong system that we have already built over 70 years, we have reduced such large sections of our people to penury in this matter of 6 weeks. It is really something that completely astonishes me that we have turned the clock back. I remember when the lockdown was announced, the reason for the lockdown was that we were told that the country would turn back 21 years. Well, actually, it has turned back 21 years, it seems, but for altogether the wrong reasons. I want to actually share, you know, completely Sujatha and other the concerns about the virus, by the way. I mean, you know, one should not mistake for a moment the concerns about the lockdown as suggesting the virus is not a threat. This would be a wrong conclusion. And oftentimes the media has really played this as a dichotomy. Oh, so if you don't really support the lockdown, do you think deaths are okay? This is a very false dichotomy. And I think it's extremely important in our panel to be very clear that these are not opposites. The virus is a real threat, and so is a poorly planned lockdown. I think I want to just turn this conversation a little bit into the positive direction. It is true that the numbers are increasing, but that could be the price of success. And let me explain to you why. The numbers could simply be increasing because we're actually testing more, and community transmission has been going on for a long time, notwithstanding what some of our senior scientists say, and that actually we're doing a better job of finding cases. This is what we in fact should have been doing for a long time. So what I would urge is for us not to immediately start panicking. Somebody said earlier, you know, this red, green, orange zone nonsense has to stop, because imagine in Goa, for example, if they find a case, and they will, because the virus doesn't stop on the Goa-Maharashtra border, it doesn't need a visa to get through. It will get to Goa. It would be an absurdity if suddenly you switch from green to red. It is a meaningless and mindless panic reaction. I think we have to learn that this virus is going to spread. We need to figure out ways to minimize the spread as is feasible and acceptable and just within our context, and to minimize, of course, the lethal consequences of the virus. I also want to stress here that Kerala has been able to do it. We don't have to look at another country. We can look within our own country. In the north, Bhilwara has been able to do it. And if you consider what these places have done, it's bottom-up planning with very strong local leadership. And I think, of course, Keshav and others have already touched on this, so I won't say any more. I say this only because I think there is hope here. We have succeeded in the past. We've beaten polio, for God's sake. You know, and I think we've done it. Of course, Sujatha and Keshav, as leaders in the country, in the policy area, can speak more to this. But we didn't do this through high-tech hospitals, Keshav. We didn't do this through intensive care units. We did this through all the remarkable innovations, the frugal innovations that the National Rural Health Mission and then the NHM have continued to support. And I would love to see a lot more of that actually being deployed in the future as we go forward with controlling this epidemic. There's one thing that may protect us, Harsh, and also the urban poor, and that's that they're mostly young people. And I think it's important to remember, somebody mentioned this question about high mortality in Europe and North America. Yes, it is baffling. But I think one very important piece, which I think not everyone is aware of, is 50% of all the people who've died in the US are people living in care homes for the demented. Now, you know, this is a very unique ecosystem that does not even exist in India, because most people with dementia don't even survive more than a few months. Of course, that is another tragedy in its own right. But nevertheless, the fallout of that is that we don't have dementia care homes in India. And so I think it's important to bear that in mind. About 20% of all the people who live in certain parts of the US are over the age of 65. I just checked the census report. It's about 4% in India. So I think we are protected to a little bit at least, and that is an advantage we have. We often hear about the demographic dividend. Well, maybe this is another example of the demographic dividend that might protect our country, our people, from the worst that we've seen coming out in the US and North America. So I want to be more positive about this, and hopefully this conversation can start thinking about the strengths of our system, the strengths of our community, the strengths of our experience. And finally, one more thing I want to say before I forget, and I don't get a chance to say this. I hope we can acknowledge an epidemic is not just a biomedical business. It really, I mean, earlier I think Sujatha mentioned the committees that have been formed. And I don't want to critique the specific people on that committee, but what I want to say is I'm astonished that we don't have any social scientists. I mean, an epidemic is a social phenomenon. It is not just a biomedical phenomenon. And I hope very much that we use the time going forward to constitute at every state level a committee of people who span the necessary expertise and disciplines, including community development, so that when we are planning our responses, we're not just planning it in a narrow way, thinking only about the virus and how we can reduce deaths, but also about all the other fallouts and consequences of our policies, which only social scientists who are embedded in communities, I think, can really bring to the table.
So thank you, Vikram. I think that, you've really set the ground for the third and probably the most important part of this conversation, which is about what is it that the state needs to do in the immediate future for containment, for protection, with a high focus on equity. I wanted to sort of just state 2 or 3 sort of particular challenges I'm sure they're before you. One is that India has, has stymied its primary health infrastructure, but most of all in urban India. Keshav, actually, when Keshav was secretary, I was asked to chair a committee which looked at the urban health mission, what it could do in urban India. And we had proposed a very extensive network of primary health services in urban India. Obviously, none of that happened, but if it had, we would have something to work with. Without, what does the future hold? If it has to be community-led, without community structures of public health in large parts of the country. The second, big challenge, not second, there are many, but one more that I wanted to focus on was the role of the private sector. The private sector has 80% of our doctors, 80% of the ventilators, 66% of our beds. Yet its contribution so far to fighting COVID is about 10%. Is this abdication? I believe it is abdication, Vandana, and we had a discussion. Is it that the government has had no space for them? Should we actually still think about nationalizing private health in this health emergency time? Otherwise, how will we cope with not just COVID, but all the other health emergencies? What is, since most of our betting has been, and our investments have been in the private sector, how can that be brought in? Or is it going to be just the 20% doctors in the public health system who will have to carry this burden? And the third is, of course, the implications of hunger and the distress, which I think is I would again repeat, is already catastrophic. We just need the eyes to see it. While writing this piece, actually, it was summarizing what I'd seen over the last several days on the streets. It just broke my heart just writing the conversations that people had. I remember one man was just in complete rage. He said, they're telling us to stay locked up in our homes. Do they expect us to break the walls and eat the pieces? Women were saying, I haven't been able to light my stove for several days. These are the 3 challenges that I want to lay out while we think about the future. And one more request was that in between, if you could just look at the questions, because we would also, the viewers who are sending in questions. So while you also respond, if you could also look at the questions and see if you want to respond to some of them as well. Vikram, I'll go back again in reverse direction. So Vikram, come back to you.
Okay.
Where do we go from here?
So I haven't had a chance to look at the questions yet, but I will do if we have another round of, at the end. So I will look at those after my remarks. So I just want to be very brief so we can go through some more questions as well. And I won't speak about all the issues, and hopefully maybe others will speak, especially about the third issue, which I think is the most difficult and painful of all. But let me just speak to the issue of the private sector. See, Harsh, I think the private sector has for 70 years been pretty much excluded to a large extent from public accountability, public ownership, public engagement, public financing in every respect. And of course, again, I'm sure Sujatha and Keshav will speak to that. And so it's suddenly a little, the horse is bolted. It's suddenly a little late in the day suddenly to say, oh, we have to, now bring the private sector in. I do think it's an opportunity though. And let me tell you, when I speak to my colleagues who work in the private sector, I think a significant proportion, it's a minority, but a significant proportion would want to play a role in India's national health future. But not in a way that is often portrayed that we're going to come and regulate you without any kind of potential opportunity attached to that. So I think it's a carrot and stick approach that I think has to be balanced. At the moment, for example, there is a talk of, again, making this a policing issue, that we're going to sort of bring all the, private doctors are going to be fined and if they don't keep their hospitals open, etc. I'm not sure this is the way that one engages with a section of the health system, which has historically been completely ignored by the public system. I also want to say one more thing. Let's be absolutely honest. The private sector will only play a small role, even if they're fully engaged. If infant mortality, maternal mortality in India have reached the level that we are currently enjoying, it is not because of the private sector. It is really because of India's public sector. It is because of India's frontline workers. It is because of India's district hospitals. And I think we should really see this as our greatest asset. And if there is truly an opportunity that is staring at us in the face today, that the coronavirus has reminded us, is that our public sector is really the foundation of all our healthcare, not just those of the poor or the vulnerable or the marginalized, but national health must be driven by its public healthcare system. The private sector can play a role, but I don't believe that the fact that 80% of doctors work in the private sector means that we should abdicate to the private sector, in fact, our healthcare security. I'll hand over to the next speaker.
Vikram, you've said exactly what I was going to say, so I will not repeat it. Let us hope that once we are through with, or at least once we're through with the worst of COVID-19, that we will see serious government investment in developing the public health infrastructure, both in the urban areas, which Harsh talked about, and in the rural areas. And this includes more government nursing and medical colleges. I think part linked with this whole private sector question is the fact that we have completely given over medical education to the private sector, not just the practice of medicine, but the teaching and the establishment of medical colleges. So if we can get more public investment in the government systems, I think it would be the way to go. And that's, I do hope, I think there's a fighting chance that the government may have learned from this COVID experience and will think of working in that direction. Thank you. Sujatha?
So, the three questions that Harsh asked, and both of you focused on private sector, I have nothing really more to add except to say that, private sector, I don't see any possibility of India trying to nationalize them. I don't also think it is an advisable way of going about it. Spain, I don't know what model it was, and I have no idea what they did, but that's not what we should work on. Where I'm certainly concerned about the private sector's role in this epidemic was, even if they didn't do COVID cases, even if they didn't get engaged in that, but the way they went around the pricing of the tests, I mean, that they could have taken only a non-profit based pricing they could have agreed to, which they didn't. And secondly, they could have attended to the non-COVID cases. I mean, I remember very clearly when the Health Secretary Bihar spoke to me and says, do you know the whole private sector is just packed up? I mean, why did they pack up? Nobody told them not to treat non-COVID cases. And they were so afraid of, they didn't have tests, they said. So they didn't know treating of other patients because they didn't know whether they were COVID or not. I mean, that is completely abdication of their responsibility and highly irresponsible. That said, I do think that one thing this COVID has done is the government has now turned the clock and become more sensitive and aware of the NGOs and civil society. You remember how they have treated them the last 6 years, but now there's actually a committee and they keep calling up the NGOs saying, can you do more? Can you do this? And so on and so forth. So I hope there will be some thawing of the relationship, and I hope they do get incentivized and agree to use more of the civil society and the NGO sector in health. I mean, the HIV success, I have to admit, is largely because of the role that the NGOs and civil society and the peer populations and the peer group, the key populations played in its success. I think that's what has to be done, not really rely only on the tertiary private sector. Regarding the urban, I think there has been some understanding and some efforts have been made to try and expand urban health, but much more needs to be done. Telemedicine is going to be definitely strengthened. We've seen the power of telemedicine in trying to bridge the gap between access to a specialist and so on. So I think that will get a greater traction in the years to come. But what I am very worried about is, I doubt whether the government is going to put in more investment in health. I don't think they will learn the lessons. The government is going to have a GDP less than 1%, maybe 0.78%. They're not going to have money. They have to revive the economy, and the economy, the engines of economy are saying it's going to take them 2 years. Almost every rung of the economic engine is seeking subsidies and seeking help. They're going to come up with a huge package for MSMEs and so on and so forth. So in all these kind of competing pressures and competing demands, I think health will again may fall into between the stools, largely because once they've contained and handled the COVID, the sense of emergency will move. I hope that doesn't happen. I do hope that they give more money for health, and I do hope that they change the priorities that they had laid out earlier for health and focus more on primary health care, on public health capacity to deal with the infectious and epidemics and diseases and basic primary health care and public health policies, including strengthening of district hospitals. So that's where the health part is. Regarding the hunger and the distress, of course, it's catastrophic. And what I don't understand is why the FCI go-downs have so many stocks of rice and wheat and why there is still this hunger. The mindset of the central government, which was there in 2010, it still continues, is wo rice or wheat hamara hai. What do you mean by hamara hai? How can you be different from the people who need it? So, and the states are not getting enough money to be able to buy that rice even at the subsidized rates. So I hope that there will be some kind of a change in these dynamics between the financing of basic foodstuffs and basic goods like this at this point of time between the central and state. Finally, what was the first point is that primary health care, yes, will get a boost up, as I've already covered. I think at this point of time, this is what I have to say.
Thank you so much. Sorry, I got suddenly my connectivity broke, but I'm back. So Vandana, how would you like to? What are the sort of big things that you would like us to do in the coming?
So one small thing about the private sector. I mean, I think it's one can't. I mean, it may, however wrong it may be, we can't underestimate the amount of care that the private sector is providing, with all its attendant problems and difficulties and the wrongdoing. So there's no getting away from that. So I think it's simplistic to both to blame them for this particular situation that they're in, or to say that we will, that they can be let off from it. So it remains what our strategy has been, and I think this is a very good opportunity for that, which is to regulate the private sector and to contract in and to make sure that Clinical Establishments Act, the Patients Charter, and all these tools that we have created for bringing them to book really and making them toe the line, that I think has a certain impetus in this pandemic, and we shouldn't lose that. So that's all on that front. I was looking at the question and answer box and the chat box, and there are two things that I feel that should be responded to. One is very brief. Somebody asked a question about herd immunity. Good point. That WHO is saying there's no such thing, but I don't think, well, WHO is wrong to say that. They should say they don't know enough about it, but they shouldn't say that there is no herd immunity. I think doctors and people who deal with viruses and epidemiologists, we all tend to agree that there is likely to be some degree of herd immunity, and that's also something hopeful for the future. Somebody asked a question which I think this group should also now answer perhaps, and I won't get into it too much, but maybe the other people subsequently, which is how exactly the lockdown now, this lockdown 3 should be lifted. I mean, this afternoon, chief ministers and the PMO is sitting to decide things. And I think that to be able to very precisely say this is now what needs to happen is, I think the group that's attending this meeting would also like to hear that. And there are very specific kind of sense to that. And I'll leave it to Sundar and others to really say that.
Thanks, Vandana. Sundar, what would you recommend as your big asks at this moment?
So on the private sector, I have a slightly different thing to say. The larger issues of how do you engage with the private sector is there. We can't quite deal with it. But there's a particular context, since Spain was mentioned. I think there's a relevance there. Even in Wuhan, it happened. The question is of placing certain private hospitals under public authority, under a unified district command, so that you use them as additional capacity, infrastructural capacity, for two purposes. Some of them you use them as additional capacity for isolation. They are not advanced ICU centers. You need isolation beds. You need people with mild and moderate home isolation is not a great idea. They are going around, some of them will turn severe, they will go around seeking healthcare, they will infect people in the process of sick. Some of them will slip into pneumonia and die. Italy had a lot of home isolations leading to deaths. So you would require isolation centers, which these are an extended capacity. Instead of closing down a busy district hospital, a hospital that is already shut down is an ideal thing to bring under a public authority, and the district administration admits patients on those beds and keeps them under isolation. That's the model. Similarly, you place under public authority extended ICU facilities where very few are available. Usually these will come with negotiation. So you're not really talking of taking over. There are hospitals which are willing to negotiate, and at some point they are not able to run also. There's a crisis going on within the private sector. It's a paradoxical issue, but there is an economic crisis also. So you can actually place them. Right now you say we will place them under public authority for these 6 months, 3 months, and we'll take care of whatever the salaries you're paying, but you use them as extended capacity. This means you don't need to shut down your main public hospital and put your cancer patients under the flyover as they were doing. This means you're actually using redundant capacity or underutilized capacity, because there's a lot of underutilization in private sector, believe me. And rather than taking your 150% bed occupancy district hospital, emptying it out and keeping it empty for a COVID patient to arrive. That's the real thing, that with the other issues can be sorted out regarding that. There's another thing on the testing, because it's come up in the question. Kranti has asked this question. I want to say, when 87% are asymptomatic, how do you test? Now, here's a thing that is a bit counterintuitive, but please listen to it. Don't bother about that particular asymptomatic for now. That's a different issue. I'm not saying you don't deal with it. You'll deal with it with zero surveillance. You will want to find out how much asymptomatic it is. Your primary role is people who are symptomatic, irrespective of contact history. And that's the key buzz over there. If they are symptomatic, 3 or 4 days, look like COVID, sound like COVID, make sure they are tested. Otherwise, they are going to wander around and spread disease. Maybe test them at home or bring them by dedicated centers and test. So all symptomatic patients, because flu is far more sensitive to social distancing than COVID. So it should disappear first. If you test that, you have, even clinically, if you manage that, you have a disease surveillance in place. Test all, but if not, at least a proportion of people who are symptomatic. Secondly, by different models, though asymptomatic can spread and there will be some asymptomatic who will spread a lot, the symptomatic people and the more severe tend to shed much higher viral loads. Therefore, it's very important that we actually get this whole thing done So that it's almost like a right to get tested if you are symptomatic. It's important because you don't know whether it's worsened, and they will be much more willing to get to a hospital for isolation, especially if it's a private hospital converted into an isolation bed, not a railway coach. It should be used to transport migrants rather than isolation beds on this. So these are some basic, there are many things which are going wrong in the public sector, the so-called public health response. Why, for example, after 7 p.m. all activity must shut down? It's a phenomenal piece of absurdity. Does the virus spread at night? Are you afraid of vampire bats? What the hell happens after 7 p.m.? Why can't you say the shops will be open till the last customer is served? So please don't crowd out. You just see if there are 50% ahead of you and come back later. Don't worry, even if it's midnight, we'll get your booze and go back. We've just done. That's a different issue about what you want to do. But I'm saying, what is the big sanctity about? Is the police force going to be less used? No, they're going to manage the curfew. Why are we closing at 7 p.m.? A whole lot of these things are even as, it's totally random, non-thinking versions of things. Why do you confine a particular, are you more at risk if your neighbor's apartment has got COVID-19 infection? No, you're not. At some point, the whole logic of these containment strategies, these timings, the mixing amount, none of them make any sense because you actually have no data about where social mixing is going. So when you come out from the thing, other places are doing it very judiciously. Japan, for example, does not think public transportation is their point of mixing. They allow that. Sweden, for example, allows schools. They have figured out for them that's not the problem. So there is data available from, it's now available even in India, about where actually is the point, and therefore a point that Vikram made in the very beginning, you don't need to restrict all activity in a lockdown, judiciously choose 1 or 2 particular activities and tone that down because it will reduce the frequency of mixing. So much of it is unthinking. One wonders at one, the decision making seems to have just gone bizarre on these issues. So I'll stop with that. There are so many practical things, Harsh, that can be done, that can cope with it. There are even this migrant bringing it back. There are many ways in which it could have been done. Why are we making it sound so much more difficult than it is? And I think we must get the Ministry of Home Affairs out of it. We must write the Disaster Management Act where we say home ministries and the police force will be not central to managing it. That's, I think, one of the big things that I've learned from this pandemic management.
Yeah, no, thank you so much, Sundar, for many, many wise things. You know, the 7 o'clock at night to 7 o'clock in the morning really sort of knocked me down, because it is classically what you do in a law and order curfew. If there's a communal riot, you want people to be indoors at night. This is not a law and order curfew. This is
what will the
Harsh, Harsh.
Yes.
No, in Hyderabad they're saying this is only because of Ramzan.
Okay.
Because then they come out for iftar and then the mornings they do. So I mean, it is so communalized, the whole thing.
But in Hyderabad, many places have no Muslims. They're all.
No, but they can't just do it typically for one place. No, then it come out even clearer. No, don't mistake them. They're no fools. They have their agendas.
They know. They know what they're doing.
But this is one point, Harsh.
But what is stupid, Sundar? What is stupid is the cars. That in orange zone you can have a Uber with 3 people, but in the red zone, I mean, how does the ownership of a car change the COVID? I don't know.
Nobody feels obliged to explain this is the reason why 7 p.m. There is no reason offered. These are just random. You shut this down, you open this, you close this down, and there doesn't seem to be a requirement to have a reason. So
and the extraordinary power that it has given. You know, I've been speaking to people around the world, and governments which have an authoritarian tendency are loving this moment. And they take, because they've never had this kind of control where they can control every aspect of our personal and social lives.
So I love Kerala, but I must say that, you know, this sort of power at your hand to do things can manifest even there. Now, Sundays they have a curfew. Now, whatever happened to Sundays? Now, why poor Kerala must have Sundays? They just felt that everybody was doing something. They too should shut down something. I don't see actually, and Sundays was the least damaging, they thought. I can't think of any other reason for Sundays as different from Mondays.
Vikas, your remarks, and then we'll come round for a final round. I request all of you to again look at the chat questions. Vikas, if you would like to come in with briefly, what are your asks at this moment?
Yeah, you see, the issue of private sector and its involvement came in. I think it's very important. First of all, the private sector, which is, I think, the source of problem, or is the big corporate sector, tertiary sector, which is organized private sector, which has moved into health as a capital. And, you know, I may underline the extent of the problem by this quote, which was there as part of Draft National Health Policy 2015, which stated as much that corporate hospitals should not be bothered to care for the poor because they are contributing to the national economy by contributing to the economic growth and through medical tourism. I mean, this was a statement which was written down in the health policy of a third world country like India, given the nature of poverty and all other problems that we have. So, you see, if you see private and public as in separate silos, I think we would have lost the game. You know, the very requirement that such organized private sector has to be controlled and undermined to grow the public sector. You cannot have a functional public sector which is robust enough, which is capable of rising to the requirements of the people, so long as it is the private sector which dictates policies in as detrimental a manner as I have just quoted. Okay, so it may sound, well, maybe people will have differences on this, but that is my considered opinion about this. As far as hospitals are concerned, I think, yes, there is a need to take private sector under the control of government authorities and all. And I mean, why shouldn't it be possible that the doctors, the staff in those hospitals and all, for at least a foreseeable period till such time that we anticipate that this pandemic can poses a potential threat, why can't they just come and work just as doctors and employees and nurses work in public hospitals?
Yeah, a nationalization, a temporary nationalization.
Yes, I mean, what else is our health services meant to be? And one thing why government has to step in is we must understand. You see, in the shareholder responsibility primacy model of the private health care, their whole canvas, it just does not, it is not capable of figuring in all the other issues that we are really having to deal with at this particular moment. It will never occur to them. And they just, by their structure itself, they are constrained not to be able to take such issue. So the government has to step in. That is provided the government does so, and I don't see any signs of that happening in near future. Now, I mean, the tragedy of this is that while public sector has simply just stepped aside in this whole calamity, even the private sector has stepped aside, even the public sector has been incapacitated to a large extent in terms of restricting it only to catering for COVID. I mean, and the initial thing that was said was, you know, to avoid crowding and all that. And I mean, why couldn't we have had, as Sundar was telling, why couldn't we have had morning OPDs and evening OPDs if that was the need? Why is it that we could not have had extension services of these hospitals where clinics were organized in the localities and all, such that they could be easily, I mean, patients could be screened and filtered out to those who needed to actually go to the hospital? That could have been done. All of this would have, rather than having a standing kind of whole infrastructure and sitting idle. except for just doing COVID and all that. Now, I mean, these are the medical aspects of it. Government also needs to take into control, the production facilities for, say, antiviral drugs or anti-malarials or the potential which are there. Government needs to step in very robustly into the research that is required for controlling this public, you see, there are many questions. Tomorrow, suppose there is vaccine available. Now, what do you do? Would you make it a part of national vaccination, universal immunization program, as you have done with Japanese encephalitis in Eastern UP and Bihar with no result, and same number of children continuing to die every year? So, and what is going to guide? If tomorrow we do have some such instrument available, what is going to guide our usage of it? How best would we put into use? Or is it just that some multinational will say, now this vaccine is there, you pay up this much cost, and you just give a silver shot to everyone? These are the questions which can only be addressed if we have that orientation to do proper research into all of this. And the time for doing that is now. It will not be when we get the vaccines. Okay. Now, another important issue which has to be addressed is that of hunger and is that of livelihoods. Okay. My fear is government will again open its coffers to the big sharks, give them all kinds of concessions and all. All the big sharks which have already cost hugely worth tens of lakhs of crores in NPS to the public exchequer, they will be given. Okay, and as it is, I mean, they are tightening their screws mercilessly by abolishing all labor laws, and even otherwise they were not being implemented. That's another thing. But then the thing is, they see the way out in this way. Now, I mean, why is it that they cannot reduce the number of working hours and all, so that more people, more hands have the work to do? Why is it that government cannot ensure that, okay, we will say pay full or 75% of the salary of these workers for small, medium, and micro, small, and medium sector industries or the informal sector and all that? And the PDS needs to be ramped up hugely, and not just the grains. I know in Delhi itself, I mean, we've been involved in arranging food and all for some families. There are families who have got the grains. We could manage to have it served at their house and all, but they run out of gas to cook it, and they don't have any cash to get all of this. So the PDS has to provide for oil, for pulses, for various other things which go into ensuring food security of the people.
Vikas, thank you so much. I mean, I think these were brilliant, the larger sense of public health linked to equity. And that is really, we have just a limited time, and I wanted each of you to, I had a request of just a closing remark, but with that same, talisman that I spoke about in the beginning, about Gandhiji telling us in times of great doubt to remember the most vulnerable person, and leave, if you could leave us with one thought which would make greatest sense to that most vulnerable person. This is truly a defining moment for us. I think as a country, and as a civilization, in terms of what we do now. And so what is that last thought that you wanted to, you might want to reiterate something that you have said or add something. What is that last thought? How would we, how can we be proud or not ashamed when our grandchildren look back at the choices that we made as a collective at this moment of crisis? So Sundar, should I start you?
I have no great wise words. It's very difficult to summarize all this in just one thought like that. I'm not used to. I can only say that lage raho. I mean, in some sense, you just have to. There is no simple solution. You just, wherever you are, whichever way you can push, you have to push, because that's what the purpose is about. But these are difficult times. These are times at which one must just stand one's ground and reach out. I keep having to speak this to many webinars. I'm talking to my communities, I'm talking to Science Forum members, I'm talking to some people can help out in local relief, some people can help out in writing to officers, some people, but wherever you are, push, because there has to be this understanding that there is so much. So one of the things is some of the basic issues we need to reiterate, the basic ethics of it, the basic democracy, do not allow the state to become more autocratic, more centralized, more surveillance, more repressive than it is now. And one needs to actually push with whatever energy one has left. Thank you.
Thanks so much. Vandana, your last thoughts?
Very difficult to, say anything, especially say anything summary or philosophical, because the scale of human tragedy is just so heartrending and so disastrous. But, somebody raised in the chat box and question answer, very important issue. I think it was Ritu, perhaps it was Ritu Priya, about we have not spoken sufficiently about communities and community engagement. So all of us are actually very engaged with that point. So what keeps me going, I mean, again, community engagement for me is it's not a romanticized thing. It's very real. And I think we're seeing the best and the worst of it. So I see every day, that's what keeps one going, is the amount of kindness, also generosity that one sees at a human level. And of course, the amount of, not so also, where people who may have crores in their bank are not giving rents, not giving wages to their, casual workers, domestic workers, and so on. So we see both of it and in a much more exaggerated and dramatic way now. So let us build on the positives, and let us also start to articulate these positives more, so that we can, find common cause. I am seeing a lot of coming together also in the face of this crisis. Humanity, if one believes in human beings, then it is these severe crises that really show us what we are. And I think a lot of people are finding that they have the strength, they have the compassion to go out, take risks, and do. I mean, we have today one doctor who removed his mask and saved a life, and he just happened to be Muslim. It's so sad that one is eternally grateful for these little symbols that one feels that the mainstream will also appreciate and see. So there's a lot of that, and just greater strength to all of us, and continue. Lage raho, Munna bhais and Munni bhais, Munni bahens.
Okay. Sujatha, last thought?
Well, my last thoughts are that, I just think that with this hysteria should now come down. We must learn to realize the fact that this COVID is not going to end very fast. Even if a vaccine were to be found, which is itself going to take not less than a year, its manufacture and the last mile, by the time it reaches, it's going to take time. But, hopefully some effective treatment protocols can come. After all, HIV also has no vaccine. But because of the treatment protocols and the availability of treatment, much of the fear and stigma did go down. So I really feel this kind of blaming, this kind of stigma and discrimination and finding and blaming others, whether it's Muslims or whether it's the migrants, whether whatever, that coming out of fear should really be addressed in a very serious manner by the government giving much more information and much more understanding of what this COVID is all about. So I think, I just hope that the government also becomes much more sensitive. This whole business of social distancing, I've used this word a lot, but the more, I'm now beginning to really realize how completely irrelevant it is to our conditions. And therefore, I really think we have to, as Vikram and all wrote in the Lancet article, get much more contextual in our messaging and understanding of this infection, and educate our people. I would only like to end saying that much more community engagement, much more of building trust between the people and the government is required. And unless and until that kind of trust develops, I'm afraid we don't have, we have a grim scenario. And I'm saying this because in HIV, I saw the role that trust played. That's a very, very important aspect. And I just hope the government realizes its value soon and steers its public policy towards that end.
Thank you so much. Keshav, last words.
Do a lot more, learn from each other, since it's quite clear that the government of India is not going to provide either leadership or inspiration. And really the time for state governments to do more, raise more of their budgetary resource, learn other states like Kerala. Several state governments have been forced into taking decisions and to stand up and to address the crisis. I think we should see if this can be, how can this be strengthened? How can state government be encouraged to do or assume more responsibility, a responsibility they have traditionally yielded to government India? And maybe that is something that will come about. Thank
you. And finally, Vikram.
So yeah, it's very hard to end with anything which is very positive, but I want to just say this, that I think it's important to acknowledge that neither the virus nor the response to the virus are examples of a democratic state, that these have been thrust on 1.3 billion people without any choice. So we actually have no choice, Harsh, and I think it's important for all our people, especially those who have been hammered the worst, who of course are always going to be the people who have historically been disadvantaged, not to think that anyone here has deliberately actually heaped this abuse on them. This has been heaped on all of us, and we're all collectively suffering from this indignity. I think the positive side is that actually this is not a lethal disease. And I think we need to constantly harp on to this. It is dangerous for a small, vulnerable group of our population, but it is not generally a dangerous disease, and that we're going to have to learn to live with it in the same way that we've learned to live with diarrheal disease by boiling drinking water. And I think there are kinds of things that will have to become part of our daily life, which actually, to be honest, will also be good for other respiratory tract infections. And if we can adjust and incorporate those healthy behaviors in our everyday life, we will all be able to live with this disease and have hope for the future. Thank you.
Thank you so much, friends. It was an absolutely wonderful conversation. I really wish our policymakers find the time to listen to people like you. And I think that I, for one, learned a great deal about, what needs to be done. And I think that it calls for our best strengths in these final words. You spoke about perseverance, you spoke about reliance on communities, reliance on states, on hope, on kindness, and I think above all on solidarity. That we are all in all of this, we are there together, and the suffering of the suffering of that last person should be suffering that I outrage against and fight against, and I think that let's continue to have these conversations and continue to strive as we pass through this terrifying and defining time in our lives. So thank you all of you once again.